Welcome, everybody. This is your complete guide to prostate health. This is coming from Summit Health and City MD. Um, we take care of really just about everything there is that we can take care of in a person at Summit Health. And City MD is your go-to location for urgent care in the tri-state area. Um, if any of you have any questions at any time, please let us know by clicking the Q&A button that you can probably see in the bottom left of your screen. Um, okay, perfect. Let's move on to the next slide. So, Summit Health and City MD are one team. They work together. You go to City MD for your urgent care, and Summit Health is there for all of your routine office visits. We work together with your primary care doctors and many other specialists, not just urologists. And it's a tightly integrated network where you can think of your primary care doctor as your quarterback for your health, and the rest of us as all of his tools in everything that you might want. Um, let's move on to the next slide. So again, I'm Dr. Mark Mann. I'm a urologist. I'm a New Yorker. I was born and raised and trained in New York at Columbia, and then I moved on to Philadelphia at Jefferson, where after doing some specialty training, I went on and worked as an attending, teaching trainees for a number of years before I came and joined Summit. And with me, we have Dr. Benson.
Hey guys, Mark, thanks so much. My name is Michael Benson. I actually grew up in Miami, so the cold here in Jersey is hard for my soul. I went to WashU in St. Louis initially, and then Boston University for medical school, and did my residency urology training here in Newark. I've grown to love this special state, and honestly, as urologists, we tend to run around a lot. So I have office here in Belleville, Verona, privileges at Hackensack, and we are very diverse. So we have big cases, small cases, and we really take care of patients everywhere that we can. So next slide. When we have so many people on these webinars, it's a little difficult because what's the goal? What gap are we trying to fill? And so we just want to ask people, what questions do you have? How would you rate your understanding of prostate conditions? We want to fill whatever gap needs to be filled. So the question is, do you have no knowledge, a basic knowledge, or what is going on? So let's see, we'll give you a minute for the poll to kick in. And then we'll go right into some of the data, and we'll see. I mean, we're here to help you guys, really. So it looks like most people, 76% of people overall, have some basic understanding but want to learn a little bit more. And honestly, that's great. I mean, that's really great. That's where we want to be. And let's talk a little bit about the prostate, men's health, God forbid cancer, and what we can do to support you guys, as we enter the best decades of life. So Mark, you could give us a start.
Okay, so we're going to start out by talking about what is this? Where is this? People talk about the prostate all the time. Honestly, where in your body is it? We'll figure that out. Next, we'll start talking about, well, what does it do? What's BPH? You hear it all the time. I've got a big prostate. You've got a big prostate. She's got a big prostate. What does that mean? Okay. Now, how does that different than prostate cancer? Is a big prostate the same thing? No, but we'll talk about that. Um, and then we'll kind of complete the men's health perspective, really because so many people think of erectile dysfunction as being so crucial to the prostate. Right, Dr. Benson?
Absolutely. I mean, I think there's a lot of confusion about, urination, erectile dysfunction, prostate cancer. If I'm having urinary symptoms, does that mean that I have prostate cancer? And really, they're all so separate, but it all comes together in one place.
Yeah. How many times have I heard, "Oh, I've got a big prostate. Is that why my erections aren't so great? Is that the
Correct.
problem, doc?"
Correct.
You know?
Or the converse, people who unfortunately may get diagnosed with cancer and they're saying something like, I never had trouble urinating. I pee fine, my flow is great. And so there's a little bit of a misconception of which one causes the other.
Yeah, exactly. So, well, hopefully we'll, help to erase some myths that a lot of people have developed. So, here we go. We've got a nice picture here of the bladder and the prostate. So, the bladder is the mushroom top that you see up there, and underneath it, the base of it, that walnut over there is the prostate. And now the important thing is really um, the bladder's job and the urethra and the prostate. Now, what does the bladder do? You want it to hold the urine until it's really full, and then you want to make sure it squeezes well and empties the urine out through the urethra. That goes right through the middle of the prostate, as you can see here. Um, I don't know if you guys can see my mouse when I move it, but right through that middle of the tube, yes, thank you, is the prostate, is the urethra. And that first part that it goes through is the prostate. And as you see, it surrounds that urethra. Okay, and that's crucial. What does the prostate actually do? Um, yeah, so it's amazing. It's this little thing that causes so many problems. Um, well, it primarily produces a lot of the fluid that you need in order to make babies. Okay. Um, and we'll go into that a little bit more in a little bit. All right. Now, on this slide, you can see as you get older, what happens. Your prostate grows along with you. You know how some people, as they get older, some people have really big noses and really big ears as you get older? Right? This is what I tell people all the time in the office. The prostate's the same way, except the problem is when your prostate gets big, that pipe that you're peeing through isn't like this anymore. It gets smaller and smaller and smaller and smaller. Okay. Now, um, the important thing is to distinguish that from cancer. BPH or benign prostatic hypertrophy or hyperplasia, that's when the prostate gets big. And it's not a cancer thing, but it can cause a lot of issues, as we'll talk about in a little bit. And it happens to so many men. It's so common. Frankly, if you live long enough, you're going to get familiar with it, unfortunately. Really, starting in a person's 50s, do people start to notice that, wait a minute, I'm not writing my name in the snow when I pee anymore. Things are changing. And it affects many, many people.
Yeah, I definitely agree with Dr. Mann. It's funny. I tell patients, they say, why does my prostate grow? I said, your hair grows, your nails grow, your prostate grows. It's just a function of life. And as far as like genetics, some of it is hereditary. Like my grandfather had a procedure on his prostate. My dad had a procedure on his prostate. I'm waiting for you, Mark, to offer me a procedure in the future, maybe like 20 years from now, I hope. But it gets us all, I think.
Yeah, yeah, I gotta tell you, when I was after I'd finished all my training and everything like that, my dad told me that my grandfather had two procedures on his prostate.
Yeah.
I started to sweat a little bit.
Yeah.
It happens to everybody. So,
So yeah, so some of the symptoms, and it's interesting. I do have a lot of patients who come to the office and they'll tell me, "But doc, I pee all the time. I'm urinating so well." And I think the key that you were talking about with the bladder is the bladder has to empty well. The bladder's function is to store and to empty. And when it's not doing that, you'll start noticing symptoms. The problem is the symptoms are so gradual that people will come to the office and sometimes they come a little bit too late and you'll say things like, didn't you notice you were waking up at night 2 times? Didn't you notice that, you had a lot of dribbling afterwards? And a lot of that is just we've learned it so much in society that it's a common thing that we think it's normal. And I tell patients, just because it's common doesn't make it normal, but a lot of these things are common. So you can have people who have a lot of frequency, urgency, and sometimes we don't attribute that to the prostate, but it can be that the prostate is causing the bladder to work harder than it should. Rarely do we really see burning. Burning is usually more a sign of infection or inflammation, but it can happen in people who have a big prostate as well. Weak flow, definitely a common symptom. People might notice it more in the morning when they get a lot of hesitancy, meaning after you slept the whole night, your bladder's full, and it takes an extra minute or two to start that urinary flow. And then finally, kind of our nightmare. I mean, I really feel bad for patients when they cannot urinate. I mean, we need to empty your bladder. And God forbid you can't do it on your own. We do have to sometimes put in a catheter, and the only good thing, the good way to look at that is we will fix it. I mean, if God forbid that is where someone ended up, my goal in life is to make sure that my patients can urinate well. Um, and so then we have to talk a little bit about therapies, and it is common and it's hard as a urologist because I say it's a little bit easier because as a physician, our goals are the same as your goals. We want you to urinate well. We want you to empty. We want you not to wake up at night. And so most of my medications, I'll tell my patients, try it. If it's not helping you, if there's no noticeable benefit, then it's not the right medicine for you. But patients always want some of the more conservative management or diet, exercise. And this is tough because there is no specific food or vegetable that's going to make your hair necessarily grow slower, your nails grow slower, and similarly for your prostate. So when I talk about being healthy, I mean being healthy is a whole body experience. So we want you to drink well. So coffee, tea, caffeine, alcohol, these are all irritants to the bladder and prostate because those chemicals sit in your bladder and they really do irritate your prostate over time. There are some muscular training things that we have people do, but those usually don't help so much for just a large prostate, but can help sometimes with the urgency and frequency that may build up over time. People do ask about supplements, and it's really hard. I mean, we supplements are not regulated whatsoever. And I tell most of my men, listen, if there's a healthy vitamin that you want to take, I think that's fine. But I don't think that there is any supplement on the market that's really going to have enough of an effect that's going to ameliorate the problem completely.
What do you
So a
think
lot
about saw palmetto?
That's a great question. I mean, and that's honestly the best theoretical supplement. And why is it a good supplement? It's a good supplement because it acts on a very understood enzymatic level of one of the medications we use. So there is a medication that is able to shrink the prostate, and it's derived from something that is found also in saw palmetto. So you can theoretically use it, but there are some hesitancies because there's a worry that it can actually decrease your PSA or have some changes that might, kind of cover up an abnormality that we might notice. So if you are taking a supplement, so saw palmetto, tomatoes have lycopene, papaya, grapefruit, watermelon have lycopenes, which they say are good for the prostate as well. I do think it's important to mention it to your doctor because, I don't recommend patients not use supplements if it's something that they feel that is beneficial to their health. I just want to know about it so that we're on the same page and we have the same information. Now, as far as first line therapies, a lot of patients will even come to the office and their primary already put them on a medication. And the common ones are tamsulosin, alfuzosin, silodosin. I mean, you might know of it as Flomax, but we see a lot of patients who come already on those medications. And those medications function to actually open or relax the prostatic urethra, that tunnel that Mark was talking about earlier, and allow patients to empty better. And again, if you empty better, your symptoms will decrease because you'll have more time to fill up until you go again. On the slide, this 5-alpha reductase inhibitor is that specific enzyme that saw palmetto has that really has a very dramatic effect and can shrink the prostate. But as with any medication, it does have its own side effects. And then the other two first line therapies that are listed here are really interesting because in the past 10, 12-ish years, we are really trying to move to procedures that are so good that you almost don't even know we were there. So we're trying to fix your prostate without causing any ill effects. So we're trying not to affect ejaculation or continence or bleeding or sensation. And so water vapor is very good. Implants you'll read about, and there's a lot of them out there now, and there's even more coming. But I think the problem with them is not that they inherently have something bad. It's that we're trying to be so minimally invasive that sometimes they don't have the profound enough effect that a patient's looking for. So if you're looking for a massive change in your voiding symptoms, or you really have a giant prostate. So as Mark was saying, the prostate is small, about walnut size. Usually we say about 30 grams. If your prostate's getting to, 80, 90, 100, 120, 150, 200 grams, those are no longer realistic options for you. It's just not. And then we have to go to the more invasive surgical therapies. And the one thing I will say about them is that they are tremendously successful, tremendously successful. So a green light is a full laser vaporization of the prostate. It's very good. An old-fashioned TURP, so most of these procedures are kind of linked or graded against the old-fashioned TURP, TURP. And what I like to tell patients, a TURP, although I'm not sure how graphic this might sound, is like taking a hot spoon to ice cream. So you really, it literally looks like a hot spoon. You go through the tissue, it peels off, and you do that all the way around the prostate until you've opened a wide channel, and the patient will urinate through that channel, and it's incredible. Finally, a prostatectomy, Mark will talk a little bit about later. There's two types. One is for cancer and one is for a large prostate, in which you go in usually robotically and you're removing a very, very large amount of prostate tissue. Next slide, please.
So let's talk a little bit about prostate cancer. Okay. Unfortunately, this is the most common solid tumor cancer in men. About 1 out of 6 men in this country are going to develop it in some point in their lifetime, and they'll be aware of it. Um, Fortunately, it grows very slowly, and many men live with it without having any symptoms of it whatsoever. So, as Dr. Benson had mentioned earlier, with BPH, these things happen very slowly over time, and with non-cancerous and enlarged prostate, you slowly develop some urinary symptoms. Well, in prostate cancer, the vast majority of the time these days, people don't have any symptoms. Um, and because we catch it so early. Now, this was very, very different situation, like 35, 40 years ago. Um, and since then, we started do a screening process in this country that we'll get to in a little bit. But what are your risk factors for prostate cancer? Well, age is a big one. As you get older, there's a larger risk of having prostate cancer being found. Having a family history of prostate cancer is going to put you at a bigger risk of it. And genetics as well. Some people are like, well, I've got no prostate cancer in my family. It's just, my 6 aunts and both my grandmothers all had breast cancer. Well, there's a big relationship between breast cancer and prostate cancer, actually. And we're learning more and more about this. Um, Unfortunately, this disease, can have some really deeply personal effects, um, and both the disease itself and its treatments can make big problems for urinary control, sexual function, and as the disease progresses, your overall health, and frankly, it does kill a lot of men in this country and worldwide. Um, Now, how do we find this cancer? So, as I said, about 35 or 40 years ago, this disease state was very different. Well, the biggest reason for that is the PSA blood test. Now, this blood test has been maligned. It's been crapped on by the New York Times, by all of these major US and international publications. But I will tell you right now, there is no other screening test that has had the impact that PSA has had on its cancer. Okay. Since we started doing PSA blood tests on prostate cancer, do you know how much the death rate for prostate cancer has dropped? Dr. Benson, you know this. 50%.
Yep.
Death from prostate cancer has dropped by 50% since we started doing that PSA test. You
Yep.
look at colonoscopy,
1988.
you look at mammograms, not nowhere near the impact, nowhere near it. That said, that's and what's essentially happened is because we do this test, now we catch these cancers early. Okay. And as a result, so few people have symptoms when we actually catch it. So that's why it's so important. See your primary care doctor, get yourself your regular screening tests. If they don't mention something about PSA, mention it to them. Okay. Or tell them to talk to me. I'm happy to tell them the same thing. Now, what other tests do we do to kind of find the things that are concerning for prostate cancer? Well, digital rectal exams as well. If there's a nodule or something like that that we feel on your exam, that changes things pretty dramatically. Um, Now, we sometimes use ultrasounds to see, well, how big is your prostate? Is the amount of PSA in your bloodstream actually reflective of the size of your prostate? Because it's normally made by prostates. And you just have a really big prostate, so this makes sense. Or does that not match up? MRIs can also be really helpful in terms of telling us, you know what? This spot in the prostate, that spot's suspicious. You should aim a targeted biopsy at that spot. But even negative MRIs, an MRI that doesn't show anything suspicious, can still be concerning for prostate cancer. And the only way to actually know if somebody has cancer in the prostate, unfortunately, is still doing a prostate biopsy. Um, they're constantly looking at new ways to diagnose these things. And at this point, there isn't any other approach at this point. Now, how do we grade and stage these cancers? I'm sorry, can just go back one more time. Well, grade is something that's called the Gleason score and the Gleason group, grade or the grade group. Okay. Now, the lowest and least aggressive we've got there is a 6 or a grade group 1. And that's considered low grade. And then when we get to grade group 4 or Gleason score 8, 9, or 10, then we're talking about high risk aggressive cancers. And staging tells us how is the prostate cancer just in the prostate? Is it locally advanced or has it spread widely? And that makes a big difference in terms of expectations of outcomes.
I
Okay.
agree. And I just wanted to add one thing because I have a lot of patients who come in and there's a lot of fear about a cancer diagnosis or, even a digital rectal exam. I've literally had patients come to my office and they've delayed, coming because they're so afraid of an exam. And I think what we've learned a lot from prostate cancer over the years is that we we were probably a little bit too aggressive 25 years ago. And the key, and I think this has proliferated from prostate to other cancers, is this concept of shared decision making. And we know that, and we I would say the urologists are on the cutting edge of listening to patients because with prostate cancer, there's the whole new treatment that Mark's going to get into of active surveillance. And I think that's really important because nothing should keep you from coming to your doctor just to check to make sure that nothing bad's going on. And I have patients who I've recommended a biopsy and they're not ready yet, but I say just keep coming back. If you keep coming back, I promise we will make sure nothing bad happens. But I need you to keep coming back. And I feel like the fear in previous years was so debilitating that people stopped coming to the doctor. So no matter what, get checked, and then we can talk about like treatment or how fast or slow we can move or what it works on your at your speed. Sorry, Mark.
No, that not at all. And honestly, like Dr. Benson's saying, showing up is more than half the battle. For a lot of men, It's a deeply personal and uncomfortable thing to even think about. And just bring yourself there so you can talk about that, or even just be there to listen to what we might have to say. It makes a really big difference, and can save people's lives. Okay. So let's move on to treatments for prostate cancer. Okay. Now we're focusing on cancer, prostate cancer here that's localized. That means cancer that's still just in the prostate gland. Okay. Now, when we have these low risk, not aggressive cancers, that grade group 1 or Gleason score 6 that you saw on that other page, we're really focused on active surveillance. What's active surveillance? That's urologists saying, well, when we used to find prostate cancer, we just took everybody's prostate out 30 years ago. That's a little aggressive. Let's hold our horses. Dr. Benson, you were talking about the shared decision making thing
Yeah.
here. And I think that is huge in active surveillance because it has to be an agreement that everybody's on board with, patient and doctor. And the agreement essentially is in these low grade cancers and sometimes intermediate risk cancers is that this is not an aggressive cancer. This is a cancer that's probably going to be indolent, slow growing, and at very low risk of spreading and causing any serious problems. Maybe the side effects from urine control and erectile function are not worth the curative treatment. Okay? Because um, if you took somebody randomly and said, you are going to have surgery for this low grade cancer, you're going to have radiation for this low grade cancer, and you're going to have active surveillance where we carefully monitor this and then only do something if it looks more aggressive, they're all going to do the same. And that's, I think, probably the biggest breakthrough in prostate cancer in 30 years. Um, and so what we do is active surveillance, and we monitor these cancers. And when they look more aggressive, if they look more aggressive, then we intervene. And that only happens in about 50% of people who are on these active surveillance protocols over the course of 10 years. That means 50% of people aren't going to get treated for longer than 10 years and can avoid the urinary and erectile side effects that come with treatment. Um, and Dr. Benson, I don't know how you feel about this, but when it comes to active surveillance, I like to tell everybody if you get three urologists in a room and ask them how they do it, you'll get five answers, you know?
I definitely agree. But I think what you just said is the most important thing. We're really hopeful that there's even, 10%, 15%, 30% of people that we can prevent from us doing harm. That if we can delay treatment or even negate treatment, that we can follow you so closely that we have determined after 10 years that this is low grade prostate cancer. It is not growing. It will not change your life we didn't do harm. I think that's so important and so impactful. So yes, there are people who will convert, meaning they'll be on active surveillance for 18 months, 2 years, and then we'll have to treat them. And I still look at that as a success because that was 2 more years that you were able to live your normal life without having, either radiation or surgery or some other type of focal therapy. And that's great. I mean, that's what this is all about, is trying to get people quality time and to do the things that they love to do.
Absolutely, that's a win. Our goal in prostate cancer treatment is to minimize your side effects as much as possible while maximizing your cancer control. Okay. And I don't think anybody's going to argue with either of those things. So now, just to move along a little bit, because these are my slides. That was my last slide to kind of focus on. But before we change this slide, can we just go back for 1 second? I'm going to go into those other topics
Yeah,
very
for
quickly.
sure.
Okay. So what's the concept of focal therapy? Focal therapy, I think is a beautiful concept. It's you think about women with breast cancers, and maybe I should put my hands down. You think about women with breast cancer. They used to take out the whole breast for the cancer. Now, a lot of times, what they do is they just do a lumpectomy, just take that spot. And this is really kind of trying to apply those principles down to the prostate. If some men may have a cancer that's localized to one spot. You can see it on imaging. It's been shown in that one spot. They may benefit from what we call focal therapy, treating just that area where the cancer is. And that can be by freezing it with what we call cryotherapy or cryosurgery or high intensity focused ultrasound, or others like irreversible electroporation and things like that. On alternatively, if we were going to talk about radical therapy, so the more aggressive treatments, we would be talking about radiation or surgery. Okay, radiation usually is using external beams that you don't see, you don't feel, you don't even know is happening, although you might get a little sunburn on your skin right there, and sending energy to the prostate, to destroy those cells, to kill it. And that could be external beam, EBRT, internal radiation called brachytherapy, which is done a little bit less often these days. Um, uh, and and finally, then there's surgery, and there's radical prostatectomy for taking out the whole prostate, as opposed to what Dr. Benson was mentioning before, which is what we call simple prostatectomy. And the difference really is if you think about an orange, you radical prostatectomy, you take out the whole orange. Okay. Simple prostatectomy, you're taking out all of the orange, while leaving the entire peel behind. Okay, thereby leaving behind, and avoiding any injury to urine and erectile functions. Okay, let's move
Absolutely. And I will say just one thing about this, and this is so interesting. We were talking about, your primary care being the doctor, being the quarterback of your team. When I do have patients who are diagnosed with prostate cancer, I recognize my own bias. So Mark and I both do a lot of robotic surgery. Um, and surgery might not be right for everybody. And honestly, I've had older patients, I've had young patients who I wanted to recommend surgery, but they really just did not want to go through that. They really were more concerned about their, immediate effects and felt safer with radiation. I've had older patients who most people would recommend radiation for given their age. However, they are world travelers. They are not in New Jersey all the time, and they didn't want to deal with any side effects potentially of radiation down the line. They want to go back to their home or country. And I mean, I've taken out prostates on people as old as 76, 77. But it's a really interesting thing. So no matter what, and I don't know, Mark, if this is the same for you, but if someone gets diagnosed with prostate cancer in my office, I send them to a radiation doctor to hear what that person has to say. Because again, it's between the patient primarily and myself, but also you need other opinions because you can't just go by what Dr. Michael Benson say. It is important to get other opinions, and I'm here to facilitate that for you, not just tell you, this is what I do and this is the only way to be treated.
I totally agree. I feel as if I'm kind of the prostate cancer quarterback for the patient.
Yeah.
And, I try to shoot these resources out at them. And sometimes I think maybe it's a little overwhelming. And I say, well, you want to meet with a radiation doctor? That's a great idea. Let's do that. You want to meet with a second opinion? You want to see another urologist
Yep.
just to get their perspective on it? My ego's not in this game. I'm a robotic surgeon like you. I specialize in these things. I love doing that surgery, but it's not right for everybody, and I'm not the right person for everybody either. You got to have a good mix, and you got to have a good fit. And I like to think that the more people know and the more people understand, the better equipped they are to make a decision they'll be happy with in the long run. Because regret is always a real thing. And at the end of the day, you don't get to pick what you did yesterday. You get to pick what you do now, and whatever happened before, it doesn't matter because you are where you are now.
I agree. I agree.
Okay.
So yeah, moving forward. So speaking of the where we are now or how this relates to prostate cancer. So when I do counsel people for prostate cancer, I try to to tell them and think, really we're dealing with a disease that has an exceptionally good cure rate. So I tell them, we're talking about cancer, and really where I'm gearing my conversation is on the side effects of surgery, which is so rare. So I'm saying we're going to cure your cancer. That's a given. Now let's talk about which bag of side effects we want or what we could deal with. And a lot of the time it's incontinence or erectile dysfunction. Now, luckily, our rate of incontinence with the robotic surgery has decreased dramatically. So much so that in unique patients, I can say, I truly don't think you will leak after the surgery. And we teach them all the exercises and try to do all the rehab that we can so that that is the case. And I think it happens, greater than 90% of the time. But erectile dysfunction is complicated. And if someone is dealing with prostate cancer, it is really complicated. And I'm going to talk about all the things that we can do to try and help you. But erectile dysfunction is also very common. So on this slide, you could see we're talking 1 in 5 men age greater than 20. Okay. And then you see that number almost triple to 50% of men over the age of 40 have some degree of erectile dysfunction. So this is a very common problem, and yet I still have people who come to my office. We have our whole visit, and then the last thing they say is, "Oh, and doc, I'm struggling a little bit. Is there something you can give me?" And I'm like, "Absolutely, but we could have talked about that, in the beginning, because that's so important to me." Next slide. So what people don't like to admit, I will say, is that we're not all 18 anymore. A time machine would be a beautiful thing, but age, diabetes, cardiac disease, psychological factors are huge. So even the psychology of erectile dysfunction is really important. So you have people who are struggling with a new job. COVID was a ridiculous time where people were just stressed with their relationships, illnesses in the family. Anyway, these stressors really do cause erectile dysfunction, and unfortunately, it's a self-fulfilling prophecy. So if someone had an experience where for some reason they were anxious or nervous or stressed and they could not maintain an erection, it is likely to potentially happen again. And that's where we can come in to help you have something, some special sauce kind of thing that will really ameliorate that problem as well. But there is no single cause of ED. We'll go to the next slide because it's important that people realize, first of all, your medical history is extremely important, as well as the medications that you take. So beta blockers, calcium channel blockers, medicines for your heart rate, your blood pressure, your sugar. A lot of these medicines can interact and cause some degree of erectile dysfunction as well. So that's really important. And that's not to say you shouldn't take your medicine. It's to say we have to realize that what we're treating is an entire body. And so if you're on a heart medication or a statin because there's plaques in your heart or the arteries to your heart, there's plaques in the arteries that are going to your penis for erections as well. Diabetes is really important because it affects the nerves as well as the blood vessels. And diabetic patients do not have the same response to oral medications that other patients will have. So diabetes in and of itself is a more complicated problem. It also is a problem because I do quite a few penile prostheses, but I'll have patients who come in with a very high sugar level, and you cannot do a prosthesis on someone who is an uncontrolled diabetic. No matter how much they want to, their risk of infection is way too high. So I do think talking about that and thinking that the arteries that go to the penis are smaller than the arteries that go to your heart, your brain, legs. So any of the symptoms of heart disease, history of stroke, history of any peripheral vascular disease, surely also will give a very strong likelihood that there's some poor blood flow to the penis as well. Next
Yeah,
slide,
I
please.
always, sorry to interrupt you, but I always tell people that these blockages happen in the smaller blood vessels before they happen in the bigger, more important ones, like the
Absolutely.
heart.
Absolutely. Um, But let's talk about treatment options because that's super important. Behavioral and lifestyle stuff. I mean, listen, we need to do better. I need to do better at eating well, exercising more, watching what I put in my body. I mean, from the sodas that exist to fast food to, fatty meals and lack of exercise, we live in a very comfortable society. People, we're not walking 5 miles to school. Most people are driving, and we're just a little bit too sedentary. And exercise is real. I have a 90-year-old patient who his exercise is walking around the block, and that is tremendous. But that is not okay for my 50-year-old patient. Like, real exercise is important. So 30 minutes of high intensity cardiovascular exercise at least 3 times a week is quite important. So when people say, is there something I could do or take, I say, be as healthy as you can be, eat a clean diet, try not to have too much fatty food, and really drink. I mean, what we put in our bodies should be water, very little sodas, very little alcohol. But you need to be healthy if you want your body to work the right way, obviously. But moving past that, the medications are good, and they are first line, and they're still first line. And it used to be, harder to get. I will say, with the advent of a lot of coupon companies, we're able to write a lot more prescriptions for the sildenafil, tadalafil, and they work really well. I mean, I'm a big fan of the Cialis for daily use, the tadalafil daily, because I think that was approved for prostate health, and it also works well for erectile function. But once we've moved past the pills, we really have to kind of fine tune how important this is to you and what you want us to do to help you get to where you need to be. And
It
again, this
becomes
is
a little bit more of an investment in
yes,
yourself and more effort from the patient,
one
as opposed to just taking a pill, which people are very comfortable sometimes doing. I
right,
agree.
100%. And I think it's complicated because, again, going back to like the urinary things, I'm here for you. If a medicine's not working for you, you have to tell me, because I can't check in the office. I can't check your blood pressure and tell you, oh, it's high or low. You really have to be a good reporter of what's going on. So injection therapy is very interesting. People are scared of the concept of it, but it's a very, very tiny needle. You're able to inject it into the penis, and you will get an almost immediate erection. And it works, I would say, 8 out of 10 times. You just have to titrate the right dose. And I personally do it the first time for the patient in the office to teach them how to do it safely. And then it's very successful. Um, then we move more to like vacuum devices. And I would say that's more for kind of healing. Like, I'll have some patients who use it after a prostatectomy to maintain penile length or girth. And then finally, is a penile prosthesis. And it's funny, I will say patients, I have many patients, and I've done a lot of different things. And I will say some of my happiest patients are twofold. Patients who have had kidney stones that I've treated and they were in terrible pain, and all of a sudden they feel better. And the patients who I put a penile prosthesis in, they are some of my happiest patients, because they went from a place of no hope and despair to a place where they feel comfortable being active. So penile prosthesis, which is on the next slide, so if we go to that, is a surgical procedure. It should take under 90 minutes because it's a decreased risk of infection. I personally am very aggressive as far as antibiotic management before, during, and after, because the greatest risk of the procedure is infection, or the greatest, most common risk. Um, Basically, we are replacing the inner tubes of the penis, the inner balloons of the penis, with a device so that you can pump it up, and you'll have a satisfactory erection. And honestly, it will stay up until you push a button to make it go down. And it all sounds almost like science fiction, but it's quite straightforward. Penile prostheses have been around for at least 30 years. The newer ones on the market, I mean, honestly, I tell patients that you should last you at least 7 to 10 years. I have had to change some out, but really they're some of my most satisfied patients. And it's something that people don't even know to ask for, which is an amazing thing. Because for me, when I'm taking out 2 prostates tomorrow, and I tell them before, if you have problems after surgery, yes, we cured your cancer. That's great. But you still have another 40, 50, 40 years here. And I want to make sure that it's an enjoyable 40, that you can do what you want to do. You shouldn't feel that, oh, I was treated for prostate cancer and I'm done. We can really help you in that way and create a situation where you're still experiencing normal life. So for me, that's super rewarding. And again, some of my truly most happy patients. Next slide. Oh, so
So we're gonna go on to answer some questions. We were hoping to have a little poll at the end, but just in the interest of time, we're gonna skip that little poll and let's go to some questions that we have. All right,
you want me to start? Uh,
go ahead.
so I see a question, does testosterone impact prostate health? This is a really important question, and testosterone honestly might be Pandora's box for this talk right now. Testosterone is super important. There is so much more data that the key is normal testosterone level is critical to your body, your metabolism, your function. Does it impact prostate health? So the answer is yes and no. A normal testosterone is necessary for your body to function. There are people who have high testosterone and their prostate is fine and they don't have any issues and they don't have prostate cancer and they're normal. There are people who have a low testosterone and similarly, they have no problems or they have prostate problems. So it does exist. There is a relationship, but it surely is not causal. And testosterone is something that we do treat as well, but that is such an individualized question that I think it's hard to answer. But I would say that in most men, we want you to be normal. We want you to have normal levels of testosterone so that your body, your muscles, your mind can all function appropriately. Um, Mark, you want to take the next one?
Sure. Just going to some of the live questions here. Is resistance training, walking, hiking good or bad for low-grade prostate cancer? So I'll tell you, it's been shown in numerous studies, and these aren't randomized studies, so comparing people to placebo of any kind, of course, but people who exercise definitely have better outcomes when it comes to prostate cancer. Diet as well, although this question doesn't really go there. And as far as diet goes, vegetarian, vegetable-based diets seem to be more beneficial for people. Hopefully that answers your question there. You want to take the next one, Dr. Benson?
I see the old ones on the slide, but not the live ones. But I think we talked a little bit about preventative measures for prostate health. I see another question here about um, can we no. Can we test for testosterone? Of course, we test in the office. You talked about resistance exercise. I do tell my patients, especially if you have somewhat low T, honestly, the best first thing to do is change your habits. So diet, exercise, and weight-based exercises. Again, it is important. The lower extremities, lunges, squats, like these are real important exercise. Those heavy muscles, the quads, hamstrings, these are the ones that tell your body, I need to build up my testosterone. I need it to be higher. And I don't think people get that from as much from, the walking or even, running, but really the weight-based exercise shows benefit.
Okay. I've got one more that I want to take here. And this is a question about prostate biopsies themselves. So there's more than one approach to prostate biopsies. The older approach is where you have an ultrasound probe in the rectum because the prostate's right next to it. And that way you can see the prostate with the ultrasound probe. And the needle goes through that probe through the rectal wall into the prostate to take tiny needle cores. The other approach that's been more and more adopted over the last several years is called transperineal. That means you have an ultrasound probes in the same place, but the needle, instead of going through that rectal wall where there might be a hemorrhoid or bacteria living, because it's the rectum, goes through the skin, kind of behind the scrotum, but in front of the rectum. Now, what's the benefits and detractions of each approach? Well, the transrectal approach, pretty painless. I wouldn't say painless, actually. That's probably very unfair, but much less painful. You can do it in an office setting if somebody is inclined to with a local anesthesia. So, but it tends to be less painful. Um, On the other hand, there is a bigger bleeding and infection risk from a hemorrhoid, for example, or from bacteria in the rectum. And because we've been using so many antibiotics these days, and there's antibiotic resistance, which just in our defense, Dr. Benson, I think you would agree with this.
Yep.
When you measure the amount of antibiotics you're giving somebody in the ton in the agricultural industry
Mhm.
compared to the milligrams that we use,
Right.
we might not be at fault here. Just saying, just saying.
Yeah.
Not I'm defensive,
And it's
but
important. The antibiotics are important.
yes. Since we get more antibiotic resistance, the transperineal rate, where the needle goes through the skin, actually is a much lower infection, and as a result, is becoming much more interested. A lot of more people are getting interested in that approach. Um, the question of which one is a better biopsy in terms of diagnosis rate is still out. It's still out for debate, that is.
Mhm.
But they both have their pluses and minuses for
Yeah.
sure.
Absolutely. I agree with that. And I think one thing you touched on, I just want to go back to this, is actually comfort during procedures. And I say this for vasectomies, cystoscopies, prostate biopsies. Again, medicine is changing to be more patient specific. And I have a lot of patients who suffer from anxiety, stress, or whatever. And if I have a patient who says, Doc, I can't do this in the office, it's very easy for me to say, okay, like we can take you somewhere and you can be put to sleep so that you're comfortable, because it's not about torturing you for 5 minutes just to get the procedure done. I need you to be comfortable while we're doing this. So just a thing that I've noticed recently, that I have a lot of patients who have had some different experiences before, and I think nowadays it doesn't need to be that way. The only people I'm really doing prostate biopsies without anesthesia on are people who are almost too sick to go to sleep sometimes. So yeah, I think we try and make patients more comfortable now.
Yeah, absolutely. You have to take everybody's comfort levels into consideration, and that's why, it's so important. People have preconceived notions of what to expect with these things. This is going to
Exactly.
be horrible. Just showing up to the office, it makes all the difference. You come, we talk about these things, we find what's right for you.
Absolutely. I'm
Uh,
so happy we got to do this talk.
Thank you, Dr. Benson, so much for coming and being here. Um,
Thank
Thank
you.
you all for spending your time with us. We really appreciate this opportunity. We know your time is just so valuable. And your voice matters. Please take 10 seconds and fill out the post-webinar survey at the conclusion. Let us know how this was. Were we any good? Do you want to just hear from Dr. Benson next time and have the other guy just shut up? That's
No
fine.
way.
I don't
No,
care.
no way. But seriously, I echo what Mark says. Thank you so much for spending your time with us. I mean, we could do more of these, and it's really saves us time in the office when honestly we've covered a lot. So when you come to the office, you already know a lot of what we need to say, which is super helpful. So we can hit a lot of people at one time. So thank you for participating.